My dear friends, my best greetings from Italy. First of all, let me apologize for not having been able to come to Egypt to your wonderful meeting. Unfortunately, I've had problems in my family that have really impeded my trip to Egypt and to Cairo, and I just want to apologize for this and thanking again the organizers of the Congress, and a special thank to my friend Harris for having given me the opportunity to do this talk. And this talk is going to be about innovation and variation in bariatric surgery, and where do we draw the line? This is my first disclosure slide, and it's the classical if so disclosure slide with my case mix. I have a second unofficial disclosure slide, which is very close to my heart and which is very important for me to disclose. This talk is going to be controversial to some, and please do not feel personally offended. I don't want to single out any surgeon for any reasons at all. I just want to raise an awareness on what I perceive is a problem and has been a problem in the past 20 years. Now, bariatric surgery has gained an immense popularity in the past 30 years, and there have been several reasons for that. First of all, the increasing prevalence of obesity globally has coincided with the availability of newer and less invasive operations. And in particular, the advancement of laparoscopic techniques has rendered the surgeries both less risky and both cosmetically and socially much more acceptable. And this has created basically a perfect storm for the geometric increase of bariatric surgical operations, and we now call these periods between the end of the 1990s and the beginning of the 2000s as the bariatric surgical revolution. What were the operations that were available between 1995 and 2000? Well, basically, surgeons had vertical banded gastroplasty, VBG, Roux-en-Y gastric bypass, which was introduced in clinical practice at the end of the 60s. Gastric banding was the new kid on the block. And biliopancreatic diversion with or without duodenal switch had been in clinical use, albeit in more limited numbers, since the end of the 70s. Now, no single operations had demonstrated a clear superiority over the others, and this has not happened even today. And there has always been a need to investigate the different operations, to simplify them, to perfect them, and all of this has led to minor or major variations in the technique. For instance, the introduction of laparoscopy has made some changes to the technique necessary, like anticolic gastroenterostomy versus a retrocolic, and so on. On top of that, there have been unexpected effect on the metabolic comorbidities by the bariatric surgeries, in particular the excellent glycemic control, which have led to further investigation and further variations of techniques. Now, surprisingly, up to today, there is very little long-term data on patients submitted to the bariatric surgery up to now, and that's even for mainstream operations like the one we have just noted. And this raises the question as whether can we draw a line between a mainstream operation with a technical variation and a new innovative or experimental procedure for which we don't have any information at all. And how should we handle this kind of innovation in our surgical practice? Now, to address this issue, I did a research. And the aim of this research was to assess the clinical impact of non-mainstream primary bariatric surgical operations. So I did a systematic research on World of Science PubMed Scopus with the keywords like primary surgery and a modification of intestinal anatomy. That is, I considered only novel operations which had a modification of intestinal anatomy and which were a primary operation. I did not count revision operations, which are a completely different topic to me. I then did a quantitative analysis of the data, and I tried to understand which was the year of the first operation that was performed in the human subject, the year the technique was published first, and the time span between the first operation and the date of the first published report. I then tried to analyze the number of operated patients at the first index publication, and the presence or absence of any follow-up publications, and the date of these publications. I then tried to understand the number of centers where this new technique was being used, particularly where it had widespread diffusion and, so to say, approval. And finally, I tried to count the total number of patients submitted to the novel procedures. In all, I identified 54 papers that were published between 2002 and 2024. The median interval between the surgery and the first publication was 5 years, ranging from 0 before the approval by IRB. And the registration in clinical trial database could be traced only in 3 papers. And median follow-up was less than 2 years, ranging from 0 to 12 years. And as a first publication, having a follow-up of 12 years without shorter follow-up is quite surprising. It was quite surprising to me. Including all the follow-up publications, a total of more than 11,000 patients were submitted to novel procedures in this time span. Now, this is a quote by Dr. Alfred Blalock that you all know, and he says that it usually requires a considerable amount of time to determine with certainty the virtues of a new method of treatment, and usually still longer to ascertain the harmful effects. And I think this applies also to bariatric surgery. And the IFSO has issued a statement in 2021 about this exact topic, but the exact extent and numbers were not clear back then. Let's look at the different operations, what happened with mainstream operations. Now, we all know how VBG ended. Now, this is a paper by Microsars group in 2000, and basically, only of the patients submitted to VBG, only a small proportion could be deemed as successful. Most of them were reoperated either for weight regain or reflux and vomiting, or a combination of insufficient weight loss and reflux and vomiting. Now, let's have a look at my home city and my home institution, University of Geneva. We developed the biliopancreatic diversion in the 70s, and we did it, let me say, in the proper way. We started with an experimental study in dogs, and then a small trial in the human in 1976, and then different iterations which were all published in the literature until the final iteration of the operation. And still, only after many times and much time and many years could the extent of the benefits and the complications of BPD be appreciated in their full extent. So even the very good early results in diabetes were finally put in a different light, and to the point that this operation has been basically abandoned by us recently. Now, let's have a look at the band. Now, the band was introduced with a very, very serious and formal clinical trial in the US with, as you can see, all the results pretty well tracked, and also the number and the extent of adverse events. So in a really proper way, but still, and initially the band seemed a success in the first year. Bands were represented more than half of the total of the bariatric surgical operations, but with time, and not much time, a decade later, we are at this point. This study you all know, published in JAMA a few years ago, 25,000 patients submitted to gastric banding placement, mean follow-up of less than 5 years, and 18% of the patients underwent 17,000 reoperations, a mean of almost 4 procedures per patient. And the total cost of the band adventure, let's call it like that, was roughly $500 million, of which roughly half of it paid for reoperations and complications. So the band has basically been abandoned or almost abandoned in the clinical practice, and despite having been studied in the best possible way, in the most serious way. So the conclusion is that in the past 20 years, a substantial number of patients have been submitted to non-standard primary bariatric operations, and the medium and long-term follow-up of this patient is scarce as of today. And I think that the bariatric surgery community needs to address this issue before some other medical community or patients address it for us. And let me finish with this quote by John Kennedy, that the greatest enemy of truth is not the lie, but the myth. Thank you very much for your patience and your attention, and I really do apologize for not having been able to come to Cairo. Thanks again. My dear friends, my best greetings from Italy. First of all, let me apologize for not having been able to come to Egypt to your wonderful meeting.
So Professor Papadia unfortunately could not be here due to personal reasons, but we have actually time for 4 or 5 minutes of comments from the audience or any questions you want to talk about on this topic. I guess I'd like to just kick off by asking all the surgeons from Egypt, what is the process for introducing a new procedure in Egypt? I know in the UK where I'm from, it's quite a long process. It